Vertigo is either a sensation of motion when there is no motion or an exaggerated sense of motion. This is the so-called room is spinning and should not be confused with dizziness or lightheadedness. There are several key elements in the history that you should elicit when a patient presents with vertigo. The first is how long the symptoms last. Some causes of vertigo lead to episodes lasting seconds, like benign positional vertigo, while others develop over the course of months or years, like acoustic neuromas. You should also elicit whether there is any hearing loss or tinnitus, which means ringing in the ears. Auditory symptoms are more suggestive of a peripheral cause than a central cause. You should also find out if the patient has started any new drugs, as vertigo can be a side effect of certain medications. The classes of drugs that are most associated with development of vertigo include anticonvulsants, antibiotics, sedatives, analgesics, and tranquilizers. So, what are the triggers? Well, some of them can include a high salt diet, stress, fatigue, changes in head position, and bright lights. Vertigo is generally divided into peripheral causes and central causes. We'll talk first about the peripheral. Peripheral vertigo is a problem with the inner ear, pictured here. As stated, it's commonly associated with acoustic problems, which makes sense when you consider the proximity of the structures mediating hearing with those that mediate balance. Other supporting symptoms of peripheral etiology include sudden onset of the vertigo as well as horizontal nystagmus. Benign positional vertigo is the most common cause. It is caused when calcium carbonate stones called otoliths break free and float within the semicircular canals. The otoliths can break free due to trauma, aging, or infection of the inner ear. Typically, the patient complains of acute vertigo lasting between 10 and 60 seconds following head movement. They might also complain of imbalance, nausea, and vomiting. This can be tested by the Dix-Hallpike maneuver. This is where the patient is sitting up on a table and quickly lowered into a supine position with the head extended 30 degrees below the body and turned to one side. This should elicit the patient's symptoms and nystagmus. Now, Meniere's disease is episodic vertigo lasting between 20 minutes to several hours in association with fluctuating hearing loss. Typically, this occurs for low-frequency sounds. You also should get tinnitus and a sensation of pressure from the inner ear. These symptoms wax and wane. Now, it's unknown what causes Meniere's disease, but it is thought to be due to excess endolymphatic fluid causing distension of the inner ear. Other causes of peripheral vertigo include infection of the vestibular nerve or any other component of the inner ear. Now, central vertigo is a problem with the brainstem or cerebellum. Central vertigo is often of gradual onset and it's not usually associated with auditory symptoms. Now, unlike peripheral vertigo, which is episodic, central vertigo is often unremitting. Now, think broadly about the differential for central vertigo. It can be caused by ischemia to the vestibular nuclei in the brainstem, demyelinating diseases like multiple sclerosis, or tumors of the brainstem and cerebellum. The one, however, that will most likely be tested is the vestibular schwannoma, and this is frequently referred to as acoustic neuroma. Now, most often they occur unilaterally. If they did occur bilaterally, however, what would you be thinking about? This is actually a really good one to know. You should be thinking about neurofibromatosis, specifically type 2. Now, one way to differentiate central from peripheral vertigo on exam is to consider nystagmus. In peripheral vertigo, the nystagmus usually occurs after a slight delay and is usually along the horizontal axis. In central vertigo, the nystagmus, if present, can occur in any direction, including the vertical axis. Now, in this MRI, do you see where the schwannoma is? You should have been able to pick it out right there. And it kind of makes sense to have it there if you think about where the cranial nerve 8 enters into the brainstem at the level of the pons. Remember that both the nervous system as well as the skin develop from the ectoderm, so it makes sense that there are a number of congenital diseases with both neurological and cutaneous manifestations. The four that are most commonly seen are Sturge-Weber syndrome, tuberous sclerosis, neurofibromatosis, which we just mentioned, and von Hippel-Lindau disease. Sturge-Weber is a sporadic congenital disorder that occurs equally in both sexes. Babies usually present with a cutaneous angioma over the head and neck. Now this is an image of a port wine stain distributed in the classic V1 dermatome. It is associated with focal or generalized seizures, hemiparesis, and intellectual disability. Now remember that V1 involves the eyes, so angiomas can develop in the choroid layer of the eye. Now these kids will go on to develop glaucoma if that occurs. Tuberous sclerosis can be sporadic or caused by an autosomal dominant mutation in either the Hamartin gene, which you would find on chromosome 9, or the tuberin gene, which you would find on chromosome 16. These genes are actually tumor suppressors, so when you think tuberous sclerosis, think benign overgrowths. These are also known as hamartomas. These hamartomas can occur anywhere in the brain, the skin, visceral organs, etc. Now, neurologically, the kids present with seizures, psychomotor delays, and intellectual disability. Skin findings include adenoma sebaceum. Now, as you can see here, this occurs along the cheeks, nasolabial folds, as well as chin. One of the other things you can see are Ashley spots with our leaf-shaped hypopigmented spots, as well as shagreen patches, which are leathery plaques usually on the trunk. Tuberous sclerosis is also associated with kidney tumors, which are known as renal angiomyolipomas, and you can see those here. In patients with tuberous sclerosis, you can also have heart tumors, specifically cardiac rhabdomyomas. Now, the mnemonic hamartomas may help you keep all these strange findings straight. You can find it in your book. Neurofibromatosis can occur sporadically, or it can be a result of an autosomal dominantly inherited gene. Now, type 1 is due to a mutation on what gene? Now, you should remember from biochemistry that type 1 neurofibromatosis occurs due to mutations in the NF1 gene. This should actually be very easy to remember. Neuro N fibromatosis F type 1 1. Now, what chromosome is this on? This is found on chromosome 17. This is what you have to do with biochemistry information. Always integrate it to the disease where the information is relevant. Neurofibromatosis is characterized by neurofibromas and cafe au lait spots, which are pictured here. Other skin manifestations include freckling in the axilla and hyperpigmented macules. Neurological manifestations include involvement of the spinal or cranial nerves, meningiomas, gliomas, and hydrocephalus. Now, this image on the right shows the characteristic Lisch nodules. You can see many of them there. These are basically pigmented iris hamartomas. You can also see bony overgrowths. These are commonly associated with neurofibromatosis, as are bone cysts and scoliosis. Finally, von Hippel-Lindau disease is caused by an autosomal dominant mutation in a tumor suppressor gene. That gene's name is VHL, and this should be easy to remember for obvious reasons. However, what chromosome is this gene on? It is found on chromosome 3. Again, this actually should also be pretty easy to remember because there are 3 letters in the name of the gene. It is characterized by hemangioblastomas in multiple body parts. Hemangioblastomas are commonly found in the cerebellum, and they cause ataxia as well as headache. Retinal hemangiomas, as you can see here, are also characteristic of VHL and are diagnosed by fundoscopy. Now, importantly, VHL is also associated with what type of cancer? Well, you can take a look at our renal chapter for more details, but the cancer, which is often the most common cause of death in VHL, is renal cell carcinoma. Additionally, there's one last association that you should be familiar with. Can you guess what it is? It is pheochromo. I'm going to write it down here, cytoma. It's a long word. A patient suffers from multiple episodes of unilateral periorbital pain that occurs daily for several weeks before the symptoms subside. What type of headache is this? This is a cluster headache. Remember my illustration of Franz Kafka.